Okay, our next speaker, and this is another exciting drug, if you will, and the topic, and you've heard a little bit about it. I call it Telotristat. That's the only way I remember it, but it's Telotristat, I believe, I think. And Dr. Thomas, University of Florida Cancer Health Center is here, and he's going to speak to it. His title is New Approaches to the Treatment of NETs-Induced Diarrhea. And we've heard a little bit about what happens, how hard it is to drop serotonin levels. Short of surgery, short of PRRT, this is the drug, or one of the things he'll talk about is the drug that can physically lower serotonin. And Dr. Thomas, thank you.
Hey, thank you. So my name is Sajeve Thomas. I'm a GI medical oncologist at the University of Florida in Orlando Health. Half my practice is GI cancer, the other half is melanoma sarcoma. So I see a fair share of what I call the systemic cancers, and neuroendocrine cancer is one of that. So I'll be talking about new approaches to the treatment of neuroendocrine cancer-associated diarrhea. And really, this is a sort of an overview of sort of the common treatments that we're already doing in the clinic with carcinoid syndrome, and then a little bit into the new ways of how we're treating it with the new drug called Telotristat. And I think Dr. Wolin already kind of introduced that a little bit earlier, but a little bit more of a focused talk about that. Now, when I see patients in the clinic, they're often presenting of one of different four ways. Often it's incidental, it's picked up on endoscopy or CT scan, but they're completely asymptomatic. Sometimes they have symptoms related to the mechanical symptoms, or mechanical symptoms related to the primary or the metastatic disease where it's obstructing the food pipe or obstructing the blood pipes or the air pipes. Sometimes we have symptoms related to peptide production, amine production. The classic one is carcinoid syndrome, where it's secreting so much serotonin or a lot of other factors such as histamine or kinins, bradykinins, tachykinins, substance P perhaps. And you guys have been hearing a lot about all the different peptides that are produced from pancreatic neuroendocrine cancers, such as glucagon, insulin, and some of those are also associated with diarrhea as well. But the diarrhea is sort of driven by a different mechanism, not by serotonin. And then also we see patients who have sort of this, what I call systemic symptoms, weight loss, night sweats, sort of that cachexia, you don't feel like eating, you don't feel like drinking, and often they have rapidly progressive disease or a ton of disease if they have low-grade disease overall in the long term. Now again, I just mentioned this, when we see patients in the clinic, we talk about where is it coming from, the stage, the grade, is it functional, non-functional? It's important to know the site of the disease because sometimes the clinical behavior is very unique and different. And so for example, if you have a neuroendocrine cancer coming from the small bowel, they have a very classic case of serotonin production. You see the flushing and the diarrhea, whereas if you have neuroendocrine cancer from the rectum, not much symptoms at all. They're completely asymptomatic. Other than that, it's aggressive disease. And in some of the foregut tumors being the lung, the GI, the gastric, the thymus, for example, can also secrete a little bit of serotonin, but often they can secrete other things as well that can lead to atypical flushing and diarrhea. And you guys have been hearing this, and repetition is okay, because repetition kind of forces us to learn a little bit. I know you've been hearing this over and over throughout the day. But I'm going to be focusing on carcinoid syndrome and carcinoid diarrhea. We all know this. I've not met a person who has syndrome without disease. I think except for one patient here today who says she has a syndrome without much disease throughout the body. But often you have liver disease, often there's metastatic disease where it's producing copious amounts of serotonin and a variety of other factors. We know serotonin drives the diarrhea, but flushing, it's not really clear if serotonin really drives that. Maybe the histamines, the kinins drive that flushing episodes. We can see bronchoconstriction rarely, not something I see too often. And we heard a great talk by Dr. Connolly regarding the valvular fibrosis with prolonged exposure to serotonin. And we can measure these things in the urine and in the serum as well. And there's a lot of different symptoms we can see. Again, about 70-80% of the time is diarrhea, and then 80-90% of the time is flushing episodes. And so we've seen this before, right? Flushing, there's telangiectasias of the skin. Often that's sort of a cosmetic issue, not necessarily a problem for most patients. And the fibrosis of the valves in that lower picture. And on the right, very rarely can you have niacin deficiency because you're producing so much serotonin and not a lot of niacin. This is pretty rare. I have not seen it I don't know if anybody's really seen it in the US, but it might be something that's seen internationally. Now, the biggest thing we see in the clinic and what really impacts quality of life for most patients is diarrhea. It can be very problematic, going 8, 10 times a day. I bet someone in this room is probably the record holder of going to the bathroom in a day. You know, I don't know if anybody wants to own up to that right now, but and I think this happens to anybody. If you have an infection episode, you can be locked down in the bathroom all day. So it's very, very problematic. It has a huge impact on the quality of life, more so than I think for a lot of other syndromes. And we are very effective in treating the symptoms, right? This is an old picture. I think this picture is around all over the internet. But with cytoreductive surgeries and somatostatin analogs, we can be very, very effective in treating the symptoms. And patients are really happy, much happy if you're getting back to baseline. But if you're getting down to 3 or 4 bowel movements a day, that's a heck of a lot better than 10, 12 bowel movements a day when you're locked down to the bathroom. And so, again, people are very happy when they get better control. Now, I don't know what cats have to do with diarrhea or the bathroom, but I found this picture online. I think it makes a good point because one of the things that carcinoid patients know is they know what triggers their syndrome, right? They typically know what causes it. Some people don't, but some people do. That could be something to do with what they eat. You know, some foods that have high dopamine and tyramine, for example, caffeinated products, chocolate. I think some patients say, I'm not giving up my chocolate. I'm going to eat that still, and they'll just take an octreotide shot with that. But really, lifestyle modification, exercise sometimes can cause it. Ethanol, alcohol use can cause it as well. We heard about epinephrine. We try to avoid those drugs as well. Eating and emotion, right? You guys heard this is the 5 E's that we think about in terms of triggers for carcinoid syndrome. And then once a year, and I get somebody who's got diarrhea, but no evidence of carcinoid, no evidence of serotonin. And I just sort of remind folks that there's a variety of causes for diarrhea: secretory, osmotic, drug-ingested, inflammatory bowel disease. And now we have these new drugs, checkpoint inhibitors. I think Dr. Woolen had sort of briefly talked about that, but checkpoint inhibitors are have been incredible for melanoma patients, and a lot of times it's putting their disease completely into remission. It's been incredible. And so if there's a checkpoint inhibitor for neuroendocrine cancers, that would be very phenomenal. But one of the biggest side effects of checkpoint inhibitors is diarrhea. And so something to keep in mind. And infection can also be a risk. Now, when we see folks in the clinic with carcinoid syndrome, and if you have worsening diarrhea, it may not be worsening carcinoid. It could be another cause. We've heard about this, pancreatic insufficiency, where if you take long-term octreotide, it can suppress the amount of enzymes that are being produced by the pancreas, which those enzymes break down the food product, the proteins, the carbs, the fats that allows you to absorb it. And with long-term use of octreotide, we've had folks who their pancreas is not working as much, and that could be an easy fix. Just give them the enzymes by pills, and their diarrhea is a lot better. Short gut syndrome, if you had cytoreductive surgery, all your half your bowel taken out. Well, if food has to go through a very short bowel, you're gonna have chronic diarrhea regardless of the carcinoid syndrome. Niacin deficiency, C. diff. C. diff is a huge one. I've been fooled 1 or twice about this particular bacterial infection. If you've been admitted to the hospital or you're around a healthcare center of some kind, C. diff is huge. And the only way to treat that is antibiotics, and that can be a life-threatening event. And then drugs, right now we talked about chemotherapy and mTOR inhibitors and the VEGF inhibitors. Those are also associated with diarrhea, worsening issues. So something to keep in mind. Often those are easily alleviated by the use of just by holding the drug, and then it would typically resolve itself out. So pancreatic insufficiency, we kind of briefly talked about that. C. diff, we talked about that. Now, to talk about the treatments we do in the clinic, there's a lot of different things we do that provide disease control. You've heard about this today with cytoreductive surgeries and somatostatin analogs and tumor-directed therapy, peptide radionuclide therapy. Then there's treatments that we do that do not touch the cancer. They're just meant to treat the symptoms itself. And that's what I'm sort of going to go into with the Telotristat. Cytoreductive surgeries, we saw great responses. It's basically taking out the tumors that are producing the symptoms, the serotonin and all the factors. Somatostatin analogs, I think Dr. Fain and Dr. Woolen have already talked about this, but great responses in terms of treating symptoms. But there's a lot of different things we do that provide both disease control and symptom control And then there are things we do that just treat the symptoms, which for some low-grade neuroendocrine cancers, that could be more life-limiting or life-impactful than the disease itself. And so we would try Lomotil, we'll try interferon. Interferon is a very old immunotherapy drug, and it's maybe associated with a 40–50% response in controlling the syndrome. But, and I give interferon all the time for melanoma folks, there's a trade-off. It comes with a whole set of side effects that are different than diarrhea. Flu-like symptoms, fatigue, you feel like you've been hit by a truck. So which one's worse, the diarrhea or that? I don't know. And then serotonin antagonists. We've tried cryoheptadine and ondansetron. These are things we will try in the clinic to see if we can improve their symptoms. And then telotristat is the exciting drug that we'll get into soon, I promise. In the clinic, if you have worsening carcinoid syndrome, we'll rule out for the other things. The other things I talked about were clinical diagnosis. But if you have worsening syndrome, we will try to go higher on the octreotide sandostatin, LAR. Go to 40, 60, even higher doses. Right now, the approved dose, and the one that's going to get insurance approved, is 20 to 30 milligrams. Anything above that is typically a discussion with your insurance company, which they like to not approve. We'll use increasing doses of rescue med. I have folks who are on 1,200 micrograms. I'm sure someone else here is probably on higher doses of short-acting octreotide. I met some patients over here who are on the continuous infusion pump, and they've had great benefit with that. I haven't had to cross that road over here, and we've had some discussions about alternative somatostatin analogs, interferon. Now, to understand what telotristat does, I got to give you a little bit of basics about serotonin metabolism. Now, you get tryptophan ingested through meats, poultries, fish, eggs, and in your body, your body knows how to convert it into serotonin and also convert it into niacin. And so when tryptophan gets into a carcinoid cell, the very first enzyme that it goes through, or that converts it, is tryptophan hydroxylase, where it's converted from tryptophan to 5-hydroxytryptophan, and then through another enzyme, it's converted into 5-hydroxytryptamine, otherwise known as serotonin. And so in a carcinoid cell, this is happening pretty much a lot, especially if you have functional syndrome. In normal cells, this is not happening very often at all. And so if you can imagine, if you're diverting a lot of tryptophan into serotonin, then you're not going to have a lot of niacin around. And so that can lead to niacin deficiency. And what are the symptoms of niacin deficiency? Diarrhea, right? Dermatitis, dementia. Again, this is pretty rare, and also in folks who have pretty significant carcinoid syndrome, we tend to be a little more preemptive, maybe give them niacin replacement. But our diet's already full of niacin, and oftentimes this is not really a major issue. And again, in my practice, I haven't seen it, and I'm not sure if anybody else has seen niacin deficiency, but something to think about and something we would be preemptive about, especially if you have severe syndrome. All right, so you make serotonin, it's stored in the granules, and you secrete it onto blood, and it gets picked up in the platelets, and then ultimately further metabolized to what we all know is 5-hydroxyindolacetic acid, which is what we measure, and kind of get a sense of whether your syndrome is getting worse or if you even have syndrome. And so the question is, what if you could throw a wrench into this pathway? What if you can block the conversion of tryptophan into serotonin? Wouldn't that improve your symptoms? Would that prevent or minimize the risk of getting carcinoid heart syndrome? And so this is an interesting drug developed by the folks at Lexicon, telotristat, that actually binds to this enzyme. So if you can see that Pac-Man looking enzyme, TPH, it binds to tryptophan and ultimately converts it into serotonin. But this drug sort of binds, it's an inhibitor of that enzyme and prevents the conversion of tryptophan into serotonin. This is, again, Dr. Wallen has said this, was happening peripherally, not happening in the nervous system. So there's no psychiatric effect when you take this drug. Now, in the studies that have been using telotristat in 54 healthy volunteers, this is not carcinoid syndrome folks, they're taking 250 to 1,000 milligrams 4 times a day. And you can see on the right side, there's that suppression of the urinary serotonin levels, where the person who was taking the placebo up there, if you guys can see it, really didn't have much suppression of the urinary serotonin levels. The side effect profile, very, very well tolerated. Maybe a little bit of nausea, maybe a little bit of elevated LFTs, but if many of you were drinking last night, your LFT was probably already elevated and you didn't know it. And so LFT elevations or liver enzymes go up all the time. We see it. It typically will not clinically cause you any problems. So what about in carcinoid folks? Well, in this particular, there's two studies, small little studies. 23 patients with carcinoid syndrome had 4 or more bowel movements a day. And I think 6 of these patients were on a placebo. The rest were actually taking the drug. And if you look at the data, majority of them having adequate relief, at least 1 over the 4 weeks, 28% reduction in the bowel movement frequency over 2 weeks, and then also nearly 60% biochemical response in the urinary levels as well, none of which you saw in folks who were taking sugar pills. And in the other study, it was about 15 patients, 75 patients with significant bowel movement reduction that lasted pretty much throughout the time while they were on therapy. And so that was enough to fast track it into a phase 3 study. This is actually still ongoing right now, where if you have 4 or more bowel movements and you're on a chronic dose of somatostatin analog, so that could be Sandostatin 30 or lanreotide or whatever, even if you're on an infusion, you just have to be stable on that. You would go first to the screening phase, what we call the run-in phase, where you get this neat little PDA device. I wish it was an iPhone 6 and you could put an app on it, right? A bit nicer, but sort of this small little PDA device, very easy to use. This thing will go off at like 6 o'clock at night. I took it home over the weekend. You have maybe 7, 8 questions to answer. Very simple questions. What did your bowel movement look? How many times did you go to the bathroom? How many times did you use a short-acting somatostatin analog? How many flushing episodes and abdominal pain? You can answer all those questions with tap, tap, tap and be done within 10 to 15 seconds. Very quick and easy. You had to do that over 3 or 4 weeks, and if you were 75% compliant with that diary, then you got a chance to go on to the treatment phase. And if you weren't compliant, then you weren't allowed to continue. They really depend on that diary to actually study this. And so if you were compliant, at least 75%, you were randomized, this is computer driven, randomized to 3 different arms. The first one's that placebo, a placebo pill 3 times a day with somatostatin analog. The second arm is a low dose of Telotristat, 250 milligrams, 3 times a day. And then the third arm was a Telotristat 500 milligrams, 3 times a day with somatostatin analog. It's a double-blinded study, meaning I as the investigator, you as a patient have no idea what you're getting. And you did this over 3 months. And after 3 months, everybody gets a high-dose 500 milligrams TID. And so, and then the other caveat is if you wanted to do tumor-directed therapy being surgery or chemo or targeted therapy, peptide, you couldn't do it during the screening phase. You couldn't do it during the double treatment phase, that blinded study, the 3 months, but you can definitely do it in the open extension arm and still continue to Telotristat. So the major outcome of this is just to see, can we change the amount? They're actually looking at multiple different things. I actually summarized it into one slide over here. Change in the daily bowel movement from baseline over 3 months, and then also change in urinary levels, flushing episodes, and abdominal pain, plus a variety of other things they're also checking into. In order to get into this study, you got to be 18 years old, above 18. You got to have a well-differentiated histology, so low, intermediate grade, documented history of syndrome, so 4 or more bowel movements on average. We know what you're doing. You can't lie. Well, I guess you could lie in the diary if you wanted to just try to get in, but that on average 4 more bowel movements in a stable dose of somatostatin analog, and then patients of childbearing potential had to agree to contraception. Exclusion, if you had recent medical therapy, chemotherapy, targeted therapy, interferon, whatever, you couldn't get into the study. You just had to wait 4 weeks and then get on study. If you had liver-directed therapy, radiation, peptide radionuclide therapy, surgery, you had to wait at least 3 months before you can get onto the study. If you had other causes of diarrhea, cannot get on the study, right? So C. diff and infectious and pancreatic stuff. Short gut syndrome, you have to have a good performance status and no real heart problems before, otherwise you can't get on the study. This is that PDA-looking device, easy to use. I think my grandmom, who doesn't speak English, could use this. It's very, very easy. Just tap, 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 you're done. Again, 75% compliant, and what I've heard from the lexicon folks, 98% have reported compliancy. Very easy to do. And then this is an international study, 15 sites across the country, several sites throughout Canada, Europe, and Australia. And as of last week, it's 98 patients enrolled so far, and they're looking to accrue 120. So it's about a 20 plus spots left. to get on this particular study. Now, again, we talked about that. What if you want tumor-directed therapy? You just had to wait the first 4 months. And as you know, in the world of neuroendocrine cancer, for most folks with well-differentiated disease, nothing really is going to happen over 4 months. And so that's plenty of time to see if this is going to work, and then think about tumor-directed therapy in the extensive period. What if you live far from a clinical trial site and you're interested in a study, but you just don't have the time to? Because when you're on a clinical trial, expect to be there once a week, once every other week. The Lexicon folks actually has a nurse that comes to your house. They do the exams, vitals, blood check, a diary upload. They make it really, really easy. There's only 6 mandatory clinic visits that you need to make it to. I think it's about 6 weeks apart while you're on the therapy. And they even pay reasonable expenses: gas, hotel, airfare, and the cost for a companion. And so you just can't stay at the Ritz. You can't stay, you can't get travel first class, but just reasonable expenses to be on the study and get reimbursed for those expenses. What if you're not on a stable dose of somatostatin analog? What if you have less than 4 bowel movements? Well, they have another study called the TELESTAR study. It's a companion study. And so if you screen failed on the TELESTAR, which is the first study I just talked about, so you have less than 4 bowel movements a day, or you're not even on a chronic dose of somatostatin analog, then you could get into this study. And really, it's the exact same study without those requirements. But you have to have one of these different indications: a daily stool consistency of 5 or more on a Bristol stool chart. So I had to look this up. Type 5 is soft blobs with clear-cut edges. Type 6 is fluffy pieces with ragged edges, and 7 is watery. And if you look at a 3 and 4, if you have a sausage or a snake, you're not coming on the study, right? So daily flushing of 2 or more, daily abdominal pain of 3 out of 10, nausea more than 20%, or urinary levels that are just elevated above the upper limit normal, or if you do have more than 4 bowel movements a day but not on a somatostatin analog, you could potentially get on this study. In the same exact study, same nurse and reimbursement issues as well. And if you're really benefiting, and I'd be very curious because this drug minimizes serotonin production, if there's long-term effect of carcinoid syndrome, then I'd probably want to stay on this and not find out later that this actually prevented or minimized the risk of carcinoid syndrome. So they allow you to continue the Telotristat beyond the 9 months. It's supposed to end after 9 months, but if you wanted to continue this drug, you just go on the telepath continuation study where you're allowed to continue it as long as you want. All right, so in summary, I hope I described what we do in clinic. A lot of times what we focus on is disease control, right? A lot of things we do in clinics is provide both disease control and symptom control. We talked about the behavioral triggers. A lot of times you guys already know that. You're educating me on what's causing your symptoms. There's a therapy for refractory diarrhea that are not related to your carcinoid. Oftentimes that's a clinical diagnosis. And then there's therapy for the refractory carcinoid syndrome. And then consider Telotristat if you guys are interested in studying. I'll put a plug for a NANET Symposium. This is a physician standard conference that there'll be 3 in November. And so if you're an oncologist, your surgeon, your gastroenterologist is interested in a physician-centered, patients are welcome too, then I would encourage them to register. And with that, I'll end.